All, this is Dr. Mobeen Sayed from Drbeen.com. Today I have a very interesting study. This is by Dr. Zelenko about hydroxychloroquine, zinc, and azithromycin. His study has been approved and is published. So I wanted to go over that study and the data with you. It is pretty exciting data, and it shows how hydroxychloroquine, zinc, and azithromycin triple therapy works very well on all patients with risk for COVID-19 intense or severity. So let us start. Before that, what I wanted to make sure that I also share with you hydroxychloroquine repeatable outcomes as well. So here's a cool bean. His name is Rul Vasava, and he gave me permission to use name. And he said to me that it's a long note, but he says that, "Hi doc, thought of giving feedback on hydroxychloroquine. I had taken hydroxychloroquine 200 milligram, 1 tablet per day for 5 days continuously since 10th August. And thereafter, I was taking 1 to 2 tablets every week as preventative against COVID-19. Whenever I took hydroxychloroquine, it was very time along with 50 milligram elemental zinc." So that is what he was taking. Eventually, what happened was that he says that last tablet I took for HCQ on last Thursday, from Friday, I was feeling a little uncomfortable in chest every day for a few moments. On the Sunday, the event was with higher intensity. I took reading from oxygen meter. My heart rate was going to 110, then decreasing to 35, then increasing to 90 and decreasing. My mother, who is a doctor, after examining, told me that there are long missed beats. Till that time we reached the hospital. In about 40 minutes, I became completely okay with no feeling of unwellness in chest. My EKG was normal. I was advised metoprolol and aspirin plus clopidogrel, which I took. Next day, I did echo and treadmill test. Both were normal. I'm continuing to take metoprolol. Doctors and I believe that arrhythmia which happened to me was maybe because of hydroxychloroquine, though they thought that dose I took was low dose. And so, and he thought that it would be interesting to share it with the folks who are taking hydroxychloroquine as a low dose prophylaxis. I have in my patients that I have treated so far, there was one family, all of them. So there were 5 members, mother, father, daughters, and a son. All of them, somehow when I gave them hydroxychloroquine, they developed, actually not all, father did not develop it, mother did not develop it, but all children developed this kind of arrhythmia, that there was high rate tachycardia and then bradycardia. So those who are taking hydroxychloroquine, just be careful. I feel that ivermectin is a better choice. So with this initial heads up, let us start our discussion. It's a beautiful study, and I am grateful to Dr. Zelenko. You would see that how I am honoring him. I have made his drawing by my own hand. So this is Drbeen.com. Here is Dr. Zelenko's study. So look at the title of the study. This is a really important title. COVID-19 outpatients, early risk stratified treatment. So early treatment, but in those patients who are at higher risk. So this is an important study from that point of view, that he did not take some youngsters who already had a chance of not having a severe disease and then gave them hydroxychloroquine and then came back and said, all good. He has actually selected those patients who were at high risk and then treated them with hydroxychloroquine, zinc, and azithromycin, and then had significantly better results. So let's look at the study very quickly. Actually, let's look at my drawings. So here is the study. Dr. Zelenko study shows early management with hydroxychloroquine, zinc, and azithromycin works. It is a retrospective study. What that means is that it is a case series. So he has patients who are coming to his clinic and they're keeping their record, and then they looked back at their record and their prescriptions and then pulled the data together. So it is a retrospective study. It is a case series. That means they took their cases, the patients, and then they pulled their data together. It is an outpatient cases study. This is an important one. Remember, I have been saying that somehow we need to figure out what will these drugs do, ivermectin, hydroxychloroquine, zinc, azithromycin, in the outpatient setting? And unfortunately, most of the studies are done inside the hospitals because that is where the funds are given, and that is where the infrastructure, the platform is available to do the research and pull the data together. So kudos to Dr. Zelenko that he did it. And just once again, here is my depiction of Dr. Zelenko. I hope I did a good job. I even signed it. So back here. So this is the first of a kind study in outpatient patients. So that is one characteristic of this study. It uses low dose hydroxychloroquine. So imagine that hydroxychloroquine used in the other studies, which were 2,600 milligram or something the first day. Low dose, 400 milligram, divided into 2 doses, 200 milligram morning and evening. Low dose hydroxychloroquine, zinc, and azithromycin. And what he observed was that there was significant reduction in hospitalization and mortality. Now, please keep in mind that he had selected those patients who were at a high risk. Now, objective was to describe the COVID-19 patient outcomes in outpatient setting based on risk stratification, based on the high-risk patients. So there's a question that, do we know how he's doing? He had reached out to me via Twitter and said that he had the study and asked me if I can share it. So I would pass that along to you as well. Please share this with as many folks as you can. I can actually read you his message. He had sent me a message saying, hi, my study passed peer review and will be published in the International Journal of Antimicrobial Agents. Would you be able to help me share it all over? We'll send the link soon, Dr. Zelenko. I said, absolutely, we'll share. I will actually present it, a talk about it as well. And congratulations for your publication. And he said, thank you very much. So this is by his request. I would request everyone to please share it as well. All right, so now let's continue to look at the study. The number he chose were 141. And if you look at the paper that he has, he actually says that there were more patients, but they did not meet the criteria of the risk stratification, meaning those patients who were at high risk are the ones that he wanted to choose. So there were many patients, and out of them, this number was selected. And he gives an example of, he gives the idea of the other patients as well. I believe somewhere about 208 more patients who were also treated, but they were not high risk. And they all were treated at home and they all recovered and no death. In this group, there was 1 death. And then the control group was from the same community, other patients that were getting treatment or management from other clinics or hospitals. Their data from public health records, from responsible public health records, their data was pulled from there as control. So there were 377 patients which were similar in risk stratification to the patients that Dr. Zelenko was looking at. They were all lab confirmed COVID-19, either by PCR or by antibody tests. So the risk stratification that he did was the following. He looked at the groups. He created groups of the patients. So if I go up here, here, participants, results, conclusion, introduction, setting, patient. So here, look at these. Group A, age greater than 60 years with or without clinical symptoms. Group B, age lesser than 60 years or equal to 60 years and shortness of breath. And Group C, age lesser than 60 years, but at least one of the following comorbidities. Again, he was looking for those patients who had a risk of intense COVID-19. So, for example, hypertension, hyperlipidemia, diabetes, obesity, cardiovascular disease, heart failure, history of stroke, history of deep venous thrombosis, pulmonary embolism, asthma, chronic obstructive pulmonary disease, other lung diseases, kidney diseases, liver diseases, autoimmune diseases, or history of cancer. Pregnant women, if any, were to be included in this group as well. So he had either looked at the age-based risk or looked at the comorbidity-based risk and then included them in the study. which is again excellent. Now, prescription that was given was that zinc sulfate capsule was given, which was 220 milligram daily, but it contained 50 milligram of elemental zinc. So 50 milligram elemental zinc on daily basis. Hydroxychloroquine, 200 milligram BD, that is twice daily. So total of 400 milligram daily. This whole regime was given for 5 days. Azithromycin, 500 milligram once a day and daily for 5 days. And he says that he did not use a loading dose. In some prescriptions, in some hospitals or doctors, they actually give a loading dose and then they reduce the dose. But he did not have a loading dose. He just started with 500 milligram daily. And if you look at his prescription paragraph, if there was somebody who could not get any one of those because of any drug interaction or their health issues, then he had changed as well. But the patients that are part of this, majority of them received this. And I will show you in a second. Actually, let me show you that. So here, so patients group A, B, or C got a prescription for the following triple therapy. So I have talked about that therapy just now. So check this out. This is important. Contraindications who were not given. Patients were not treated with hydroxychloroquine if they had known contraindications, including QT interval prolongation, so heart arrhythmia, retinopathy, eye damage, and then glucose 6-phosphate dehydrogenase deficiency or the bleeding disorders. So these were the folks who did not receive hydroxychloroquine. And then continuing on, outcome, what did he want to study from this study? So in 28 days, what they were looking for was how many patients ended up in hospital or how many hospitalization and how many all-cause mortality. And I think you would be excited to see the results of it. Once again, I am going to request you to share it with as many folks as possible. I'm going to keep it short as well, just so that people are encouraged to watch it. So results. Number in the treatment group, 141. Number in the control group or the community, same community, other patients who were going to other places, 377. And here is the result. Hospitalizations, check this out, 4 out of 141. So 2.8%. In the control group, hospitalizations were 58 out of 377, and that is 15.4%. Check out the difference, 2.8% versus 15.4%. And then the p-value is 0.001, so it is pretty significant. And the odds ratio is 0.16, and the confidence interval is 0.06 to 0.5. It does not cross unity, so it is a significant number. What this means is that the patients who were on the treatment, they were 84%, they had 84% less chances of becoming hospitalized. That is pretty significant. Mortality was 1 in 141. And Dr. Zelenko talks about in his paper that he was only given, he was a patient of cancer, he was only given 1 dose of these drugs, and he ended up in hospital and died. So it is not that he was long into the prescription or the management. So 0.71% death rate, while in the control group, 13 out of 377, so that was 3.5%. However, the p-value is 0.12. So it is about 80% improvement, and it is not, remember, it is not lesser than 0.05 or equal, so it is not significant. And I want to talk, let me complete this here. The odds ratio was 0.2, so that means 80% less chances of death. And the confidence interval is 0.03 to 1.5. So it crosses unity. That makes it insignificant on both of these ends. And Dr. Zelenko talked about it. And I want to very quickly make a comment here. Last time when I talked about p-values and odds ratios, there were many statisticians possibly telling me that, hey, does it matter that it is 0.49 or 0.049 or 0.51, 0.051? And this is an arbitrary boundary, and who the heck are you to say it is significant or not? And why would you not take 80% versus 95% and so on? So my answer is, I'm not going to defend that this is the right thing that scientific community has done. But what I would say is that all studies usually talk about, when they have these kind of numbers, they just admit that, hey, this is not significant. We still want to see the trend, and we still want to say this is great, awesome. That is fine. More power to the folks who want to do it. But from a consistency of the data point of view and the result point of view, so that all studies have a similar way of assessing their outcomes, this is the norm. So if I actually go here, you would see that even Dr. Zelenko says, so this is a pretty detailed lecture. I have the link in the description. You can actually go there and see the comorbidity, types of symptoms, age groups, and the drugs that they got. So it's a beautiful set of data that he has pulled together. But what I wanted to show was, so this is the treatment group 4. So this is hospitalization. This is a graphical view of the hospitalization. And here, if you see, read this one. One of the 141 patients, 0.71%, who belonged to the treatment group A, died after being hospitalized. This patient had a history of cancer and did only take 1 daily dose of the triple therapy before hospital admission. With 13 of 377 patients, 3.5%, more patients died in the untreated group. Although the odds of all-cause death of treated patients were 80% less than in the untreated group, this difference did not reach statistical significance of 0.12 because the p was 0.12. So he himself is saying that, hey, the odds are good. It is 80% chances of improvement, so it is good. But still, from a statistical point of view, from a presentation point of view, this did not reach the significance. And he says it. So this is just for those folks who were criticizing me for saying it is. So anyways, so still hospitalization, 80% improvement. Now the side effects, the patients who took this drug, this combination, there were 30 patients out of 141 that reported weakness, so 21%, nausea 14%, diarrhea 11%, and rash 1%, 2 people. And there were no palpitations or cardiac effects that Dr. Zelenko and team observed. And again, this is a totally different and clinic to clinic and community to community, person to person difference. I had treated, I think now 300-400 patients, and then one family had this issue. And here we have Dr. Zelenko. He did not see any. And I also shared with you Rajul's message that he had been taking prophylactically hydroxychloroquine, and he had the arrhythmia as well. So this is the whole study. I wanted to just quickly go over this. The outcome of 3 different risk stratified groups, A, B, and C, was not significantly different for death. Now, this is an interesting one. The 208 patients presenting at the general practice who did not meet the risk stratification. So there were 208 more patients who received this therapy. However, they were not included in the study because their risk stratification or their risk were not high. Stratification requirements, and who were not treated with triple therapy, so they were treated in other ways, recovered at home, and no hospital admissions or death were reported. So this is the study. I'm going to go back to Dr. Zelenko's picture that I drew. I think I'm pretty proud of drawing it. So here it is. And we would stop here. I'm going to just look at a couple of questions here, and then we would stop Tomorrow, I'm going to talk about a study from Britain that says that antibodies are waning. So this just keeps coming up, and I do not know why media just keeps picking up. Anyways, I want to discuss that as well so that we do not start panicking. So there is a question. Luke says, hydroxy versus ivermectin, or use both together? So my patients and my practice, I have been preferring ivermectin in some cases. And I have been seeing that ivermectin with much more safety is able to very quickly reduce the viral load. And in some cases, I have actually combined both of them as well. So so from my point of view, the early aggressive treatment should become a protocol now, an approved protocol by NIH. And that should be, here are the prophylaxis vitamins, here is how to eat healthy, and here is ivermectin, hydroxychloroquine, zinc, azithromycin. This whole pack should be approved for doctors to use it as initial treatment. And let me tell you this, let's say somebody comes in without COVID-19, let's say they have common cold. Even then, if we have given them zinc, azithromycin, and hydroxy or ivermectin, this is not going to hurt them. So if we say that fine, in a clinic, we have approved this, look at the patient's comorbidities, look at how they are presenting. And if you feel that they do not have retinopathy or QT interval prolongation or blood disorders or meningitis or other such things, you can then give these drugs. I think we can make tremendous benefit. We can get out of this silly state that we here in the US are stuck with. And then if somebody does become intense or aggravated, for example, in this case, there were, what was the percentage of patients who actually became hospitalized? 2.8%. So out of every 100 patients, 2.8 that might become hospitalized, give them what we gave to President Trump. I think this combination would bring us to 0 deaths. So this is what my opinion is. I think this is how we should proceed forward. So just a couple of things and then we stop. So Arun says, 13 persons died. Is it good to do so? What did he give the other group? So Arun, as I said, he was not treating the other group. What he did was, so imagine if I'm the doctor and I'm treating my patients, I am treating them all with hydroxychloroquine, azithromycin, and zinc. And then I want to compare them with something because that is part of a study to compare the treatment group to some control group. So instead of within his own clinic, saying that some people would get the treatment and others will not, what he did was he pulled the data from other doctors who were not giving this therapy and who had these patients, and this patient data was available in public records. So he pulled that data for comparison's sake. So he was not saying that some patients would get it and others will not. I hope that clears this, Arun. Barbara says we need to move to one of the countries where Dr. Bean. Cool. So this is what we have. Logic says telemedicine. So here is the good news. I have been sharing some of the Cool Beans data as well with you, and you are seeing that those prophylaxis that are over the counter we've been talking about, what is that with those, when I'm now actually opening up one of the Cool Beans data that I've been sharing, what I'm seeing is that folks who are doing prophylaxis with those things that we talked about, even when they get the virus, you cannot stop the virus from coming into your mouth or eyes or nose. It does not know that you're taking prophylaxis, so I should not enter this person's mouth. It would come in and it would try to replicate, but then the drugs would kick in and prevent or help. So what I'm seeing is that even if the Cool Beans, they do become sick, they become sick with milder symptoms and recover very fast. So I think in one way, we are already serving to be able to do it. And then there are just two things left, ivermectin and hydroxychloroquine, if you become COVID-19 positive. And then remdesivir, as much as I'm not a fan of remdesivir, but I would like to use the same template that was used for President Trump. As soon as the oxygen level drops below 94, immediately give remdesivir and Regeneron's antibodies. Done. 2 days later, if there is still shortness of breath, maybe give dexamethasone or methylprednisolone, and done. That's it. Treat early, aggressively, and stop. Believe me, I think that there will be no deaths with that. So one more update from the Cool Bean, who had been going through the COVID-19 and he was positive. So today's update was, today I have had no fever and I have not taken the paracetamol either. So very, very good news. The body ache is there, but less than yesterday. Oxygen saturation 96 to 97%. And he also sent a very decent donation as well. So thanks for that donation. So this is where we are at. I love the study. Please share this. Now the duration of the video is going up, but please share this and see if more people can be saved. Let's take up that mission. I think with this little group here, we have found ways to help the community navigate this difficult time. So let's share this and help it. So Earth Angel says, is remdesivir available for outpatient? I do not know. I think that they approved it for infusion either at the clinical practice or in the hospital. So I would assess from there that yes. So wow, somebody is watching. So Mohammed bin Shaida, 2 a.m. Thank you very much. Because the preventers are safe. I've been struggling all these from the very beginning. Very good. So Luffy chimes in as well. And thank you very much, everyone, for your time today. Please make sure that you can share this. Also congratulate Dr. Zelenko, if possible, on Twitter for his study. I love it. This is the first study of this kind. So with this, but you can't sell vaccine if you have a treatment for, yeah, so that's the problem. But look, people are dying. I cannot imagine. People are dying. We can sell vaccine and stuff later on. People would still buy them, or we would, just like influenza or flu vaccine, we can say that, hey guys, you need to take at least 1 dose. That can be done next year as well. But at this time, this protocol need to be approved and remdesivir is approved. Why can this protocol not be approved while we have so many studies? For ivermectin, we have solid studies, and for hydroxychloroquine as well, we have good studies. So this study is very good. So we should, if you are someone who can help with this, please influence. We need to figure out a way to get out of this situation. And I think in this group here, with our videos here, we know how to do it. We just need to get out of it. So thank you very much. Please like, subscribe, and share. And if you wanted to support my work, there is a link in the description for donations. Thank you. See you tomorrow.